So we will start with the first presentation by Lindsey Reif. And Lindsey, you can go ahead. Lindsey is going to talk about community-based versus clinic-based HIV testing for adolescents and young adults in Haiti, long-term retention and provider perspectives. And she's coming from the United States. Lindsey?
Thank you. Thank you all for the opportunity to share our study results today. I'm Lindsey Reif. I'm the faculty at the Center for Global Health at Weill Cornell, and I work with our team in Haiti at GESCIO. So today, on behalf of our team, I'll be presenting the abstract Community versus Clinic HIV Testing for Adolescents and Young Adults in Haiti, Long-Term Retention and Provider Perspectives. This study was conducted at GESCIO, which is the French acronym for the Haitian Group for the Study of Kaposi's Sarcoma and Opportunistic Infections. GESCIO is the largest HIV clinic in the Caribbean, and in addition to comprehensive HIV care, provides services for other infectious and chronic diseases, as well as operates a large community-based outreach department, providing services in the dense urban slums of Port-au-Prince, which are some of the most impoverished and underserved areas of the region. Adolescents are the center of the HIV epidemic in Haiti. The prevalence among young people ranges from just less than 1% to just under 2%, and outcomes across the HIV care cascade are worse than both children and adults. So we all know the adolescent period is one of heightened vulnerability. Young people face a host of different barriers to HIV testing, depicted here in the Venn diagram, spanning individual, facility, and structural levels, and can be layered and complex, really resulting in very low levels of young people having ever received an HIV test. And in Haiti, this is less than 20%. So tailored interventions are really needed to seek out young people. One intervention, community-based HIV testing, has been shown to increase coverage and uptake of HIV testing among this population of young people. We recently completed a pilot project to implement one of these strategies, a community-based HIV testing campaign. And to reduce the stigma of coming to a known HIV clinic, we brought testing services out to community sites near schools and sporting events. This is one of our health workers heading out for a campaign. The HIV prevalence among participants who received a test in this campaign was 2.65%, which is 6 times the national prevalence estimate in this age group, indicating that a community-based approach really did identify adolescents who otherwise may not have sought clinical care. However, as the pilot project progressed, our study team was noting really key differences in patients who had been referred from a community campaign compared to traditional patients who would have self-presented to the clinic for testing. So following their observations, we began to track outcomes across the cascade to determine if these anecdotal experiences were systematic and were impacting post-testing retention. This led to this study, which has an objective of evaluating the 12-month outcomes of adolescents in HIV care, comparing those who self-presented to the clinic, which we'll call clinic testers, to those who were identified through a community-based campaign, which we'll call community testers. We also really sought to capitalize on the knowledge, the experience of the adolescent HIV care providers to understand their perspective on the difference between these two populations. We conducted a mixed method study to first quantitatively evaluate the 12-month outcomes across each step in the HIV care cascade, comparing clinic to community testers, and then second conducted in-depth interviews with health workers and providers to gain a deeper understanding of their experience providing care to these two populations. These are our methods for our quantitative analyses. Eligible participants included those 15 to 24 years newly diagnosed with HIV at GESCIO. Our primary outcome was the proportion of participants retained in care at 12 months, which we defined as any visit between 9 and 15 months from ART initiation, with secondary outcomes including viral suppression, as well as risk factors for attrition from care. We conducted a retrospective analysis using de-identified data from the GESCIO EMR, including 2 periods during which specific community-based testing campaigns were conducted. We extracted socioeconomic characteristics, all HIV care dates, and viral load measurements. And in our analysis, compared clinic to community testers' outcomes using chi-square tests and used logistic regression to examine associations of risk factors for these outcomes. Our qualitative methodology included in-depth interviews with health workers who led the campaigns and providers in the GESCIO Adolescent Clinic. We purposely sampled participants to ensure data was collected from those who had experienced treating young people coming from both testing routes. Interviews were recorded, transcribed into Haitian Creole, translated to English, and then 3 study team members read, independently coded the transcripts, and conducted a thematic analysis and selected illustrative quotes for each of these themes. This is a snapshot of our results of the demographic characteristics of the study population. So one of the key findings here is these really are two different populations. Median age among clinic testers is 22 compared to community testers who were younger with a median age of 21, which may not seem all that meaningful, but during these crucial ages, developmental leaps really happen with each year. A greater proportion of community testers were single, and finally, both groups reported very low income levels, but a much larger majority of community testers reported no income, 90% compared to 74% of clinic testers. So this is the HIV care cascade comparing, starting with testing through viral suppression at 12 months, comparing clinic to community testers. And among both groups, there's a really significant drop-off at each step. But initially, we really see no key differences between the groups. So as we began to dig into kind of the root causes of attrition at each one of these steps, our team was really continuing to express observing more distress, less preparedness among community testers. So we started to look at outcomes stratified by time to ART start. And this is where we started to see significant differences in these groups. So the WHO and Haitian national guidelines recommend immediate ART start, which by definition is within 7 days of testing HIV positive. This graph includes just those who started ART immediately, and it's here we see a much greater drop-off for the community testers depicted in the blue bars compared to clinic testers in green. Our primary outcome, circled in red, shows that 66% of clinic testers were retained at 12 months compared to just 48% of community testers. And our adjusted analyses confirm these results with immediate ART start being significantly associated with loss from care at 12 months. Those who had started ART faster had a 1.62 times odds of attrition compared to those starting ART later. In our qualitative analyses, 5 major themes were identified. The first was that social and community support is stronger for clinic testers. Community testing really bypasses the traditional practice of being referred to the clinic from a friend or a family member. One participant described, "The voice of a neighbor counts a lot, and self-presenters are often referred by someone they know who accompanies them to the clinic for support." The second theme is related to fear of stigma, which is heightened by not having a reason to seek care for community testers. Clinic testers come to the clinic for a certain symptom, and this can kind of be their cover, whereas community testers get referred specifically from an HIV testing campaign. Their alibi is essentially blown, and they're not able to explain their reason for going to the clinic on their own terms and timeline. The third theme is related to level of acceptance of an HIV diagnosis, with community testers being generally less prepared for a diagnosis they didn't anticipate that morning when they woke up. Clinic testers have a higher level of mental, emotional preparedness, having planned for the potential of a diagnosis that day. The fourth theme is related to a religious explanation for an HIV diagnosis. Clinic testers may be more likely to accept what one participant describes as medical theology. They may have already sought advice from a religious leader who endorsed simultaneously seeking medical and religious treatment at the same time. Community testers just haven't gone through these channels yet. And lastly, participants stress the relationship between the patient and provider as what really keeps them in care. Youth-friendly and intensive support services may be most critical at HIV testing. So our main study conclusions are, first and foremost, community-based HIV testing can effectively identify hard-to-reach adolescents, linking them to care. However, those who entered care through the community, followed by immediate ART start, were at highest risk of being lost within just 1 year. An absolute difference of almost 20% more were lost. So this is a unique and particularly high-risk population, and enhanced support is needed. Helping to disclose to a caregiver another close contact so they're not returning home alone can build their social network early. A heavy focus on acceptance of disease and the requirements of treatment, emphasizing importance, early, strong relationship with the provider that starts the day of testing, are all kind of potential aspects of enhanced support services. These interventions can preserve the strengths of community-based testing and counseling, paired with immediate ART start, and improve long-term outcomes for this population, and really carry them through the cascade to long-term retention and viral suppression. With that, I would like to thank and acknowledge our study team first, our study participants first and foremost, our study team at Jescio and Weill Cornell, as well as generous funding. Thanks for your attention, and I look forward to questions during the discussion.